Okay, so the title for this talk is When Hepatitis C Treatment is Deferred. Next slide. Reminder, the AASLD-IDS IDSA HCV guidance notes that evidence support treatment for all patients with chronic Hep C infection. The main exception is for those with short life expectancies, i.e. those who are expected to live less than 12 months that cannot be remediated by treating hepatitis C or transplant. So common is a patient who has some end-of-life issues not related to liver disease, short life expectancy. It's unlikely they will benefit from hepatitis C treatment. We are abandoning the triage approach. So due to cost concerns for hepatitis C treatments, prioritizing patients who may benefit most in Hep C antiviral therapy has been advised previously. This was had been based on degree of liver disease. So for example, patients with cirrhosis used to get priority over those who were non-cirrhotic or those who had extrahepatic manifestations or higher risk for transmission were in the past given priority over those who did not have those factors. So rather than triaging patients, they're all considered equally necessary to be treated at the time of making contact with their provider. Next slide. So right, treat hepatitis C. We want to prevent progression of liver fibrosis and resulting chronic liver disease and risk for development of hepatocellular carcinoma. Hep C treatment has been shown to decrease all-cause morbidity and mortality. There's quality of life improvements for patients treated regardless of baseline fibrosis. We can improve or prevent extrahepatic complications, including diabetes, cardiovascular disease, renal disease, B-cell, non-Hodgkin lymphoma, et cetera. And we can also prevent Hep C transmission from one patient to another. Next slide. So assessing treatment readiness, despite current guidance to treat everyone, patient selection should still be individualized after appropriate patient-centered evaluation. So examples of issues that might impact patient selection for treatment include patient capacity to comply with treatment, risk for reinfection, medication interactions, pregnancy and or willingness to avoid getting pregnant while on treatment, especially if ribavirin is going to be used, safety to the patient, concern if there's a decompensated cirrhotic, failure of prior treatment regimens, and access to medication, especially with their insurance. Next slide. So what are our checklists before starting Hep C therapy? So the general checklist for all patients is the patient willing to adhere to treatment and follow-up therapy? Are they psychiatrically stable? Do they have any drug or alcohol use evaluated and addressed so as not to interfere with therapy? We know that current alcohol and or drug use is not a contraindication to treatment, but if it's something active going on that may be interfering with their ability to be fully compliant with treatment, then that's something that should be addressed just to ensure a successful completion. We have to think about drug interactions and how we're going to monitor those if they're there. Specific for treatment with ribavirin, this is not very common anymore. However, if that's something we're using, the patient, if it's a female patient, they cannot get pregnant or planning to become pregnant during treatment and for 6 months afterwards, the patient and their partner would need to use 2 forms of birth control and have no significant cardiac or respiratory issues. Again, with ribavirin, it's rarely used, not something that we really do anymore, but in those rare situations where that's a treatment option, those are additional considerations. Next slide. So monitoring follow-up if not treated. Patient, we do recommend if they have, if they're still seeing their physicians, having ongoing education about natural history, educating patients about the fact that Hep C can cause a worsening of their liver disease, continuing to educate the patient about avoiding transmission. If the patients have cirrhosis, they should get ongoing screening for hepatocellular carcinoma, which is HCC, and also screening for varices. Patients should get vaccinated to hepatitis A and B. That should be offered whether they're treated or not, and avoiding education to avoid hepatotoxins like alcohol. Next slide. So what is our natural history education? So we can educate patients about the risk of developing cirrhosis, which ranges from 5 to 25% over a period of 20 to 30 years. Can often alleviate fears with education, just letting them know that it can take decades, not days, to progress to cirrhosis related to hepatitis C. So generally, they get an acute infection, which progresses to chronic, and then again over 20 to 30-year period, there is up to 25% risk of developing cirrhosis, and then from there, once they have cirrhosis, a 1 to 4% risk of hepatocellular carcinoma per year. Now, this pathway assumes that Hep C is their only reason for liver disease. So if they also have ongoing alcohol use, hepatitis B, HIV co-infection, if they're a male, if they're older age, time of infection, they may have a more accelerated progression and may develop cirrhosis and significant liver disease sooner than this time frame listed here. Next slide. In terms of transmission prevention education, blood donation, they cannot donate blood or semen because blood banks will screen with Hep C antibody. If that's positive, then they won't be able to donate. Avoiding transmission to household contacts. So we talked to them about sharing mainly sharp devices, so and toothbrushes and dental equipment, personal hygiene equipment, not to be shared with other people, cover bleeding wounds. In terms of drug use, counsel them to stop using drugs, get them into addiction counseling, avoid reusing or sharing syringes and other paraphernalia. Sexual transmission is fairly high risk in men who have sex with men, so they need to be counseled on safe sex practices, and also women of childbearing age need to be counseled on the risk of vertical transmission. Next slide. Screening for HCC, this refers to applies to patients with cirrhosis. So current guidelines from 2018, we do recommend surveillance with an ultrasound with or without serum AFP levels at every 6 months. And this is lifelong hepatocellular carcinoma screening in all cirrhotic patients, even after the hepatitis C has been cured. Very important they continue HCC screening because they can still get cancer in the setting of cirrhosis, even after hepatitis C has been treated. Next slide. In terms of vaccinations, and this I believe will come into play with our case today. Patients with hepatitis C should receive immunization that is recommended for a healthy individual of their age. CDC recommends the following for patients with chronic liver disease, and all the vaccines are all listed there. Next slide. So assessing for symptoms, chronic Hep C is typically asymptomatic. Most frequent complaint we will hear about is fatigue. Other common complaints may include nausea, anorexia, myalgias, arthralgias, and abdominal pain. Patients may also present with symptoms and signs of chronic liver disease and cirrhosis. Typically, they're end stage and they have obvious advanced liver disease. Chronic infection with hepatitis C has been associated with many extrahepatic manifestations, specifically cryoglobulinemia, porphyria cutanea tarda, leukocytoclastic vasculitis, glomerulonephritis, lymphoma, diabetes, and autoimmune disorders. Next slide. In terms of avoidance of hepatotoxins, alcohol and Hep C act together to promote progression to cirrhosis and increase the risk of hepatocellular carcinoma. Therefore, we do recommend abstinence in all patients with chronic Hep C. NSAIDs should be avoided in patients, specifically cirrhotic patients. They're at risk for GI bleeding and also kidney disease, so they should avoid NSAIDs. In those cirrhotic patients, for pain control, acetaminophen is safe. up to 2 grams per 24-hour period. And also important to ask about herbal alternative therapies or the supplement use. The patients may not think about those as being drugs. So we do need to dig and make sure and clarify that they're not taking any over-the-counter supplements, and if they are, knowing what they are and research to make sure that they're safe for use. Next slide. In terms of hepatic fibrosis progression, varies markedly between individuals. Variables include host factors, environmental factors, and viral factors. Next slide. Factors associated with accelerated fibrosis progression. So host factors, things we can't change for most parts of fibrosis stage, the inflammation grade, older age of infection, male sex, organ transplant. Those are host factors that we can't really change much outside of organ transplant if they get that far. Modifiable alcohol consumption we can change. Non-alcoholic fatty liver disease can improve with weight loss as well as obesity, and appropriate treatment for insulin resistance are all modifiable. Viral Hep C genotype 3 is traditionally considered the more aggressive genotype, the one that tends to historically be more difficult to treat, although with the current regimens, they're pretty much same across the board for the different genotypes. And any co-infection with Hep B and HIV could potentially accelerate fibrosis progression. Note, the level of Hep C RNA does not correlate with the stage of disease. A lot of patients are concerned about how high is the viral load. Is it, and they get scared if it's 2 million versus 2,000. The level of the viral load doesn't really correlate to the how advanced the liver disease is. Next slide. Fibrosis may not progress linearly. Some individuals may progress slowly for many years, followed by an acceleration of fibrosis progression that most often occurs in the age over 50. Others may never develop substantial liver fibrosis despite longstanding infection. Next slide. So the presence of existing fibrosis is a strong risk factor for future fibrosis progression. Fibrosis results from chronic hepatic necroinflammation. Watch for higher activity grade. So higher, that's just, again, the activity grade reflects the inflammation, which can cause more fibrosis. And so we can look at the amount of fibrosis with a biopsy or FibroSure. Typically, you're going to have higher transaminase values. But also, we have to keep in mind that those patients who start to have a lower ALT levels may have more substantial fibrosis. So we can't always go by the ALT level to know how much fibrosis there is, because across the spectrum, we can have low or high levels of ALT, and both of which can be associated with higher fibrosis. Next slide. So in summary, the availability of highly safe, effective, convenient, well-tolerated therapy has changed the landscape for Hep C treatment. Nearly all persons with a chronic Hep C will benefit from therapy. Persons with a severely limited lifespan, such as less than 12 months, are the exception. For nearly all persons with chronic Hep C, DAAs should be initiated and not deferred due to ongoing substance use or fibrosis requirements. In situations where Hep C treatment is deferred, the individual should periodically undergo reevaluation for disease progression and reconsideration of treatment, with the frequency of reevaluation individualized based on the person's current fibrosis stage, likely fibrosis progression rate, and other factors that may influence treatment readiness. And are there any questions?